Welcome everyone to this second edition of our radiology spotter case discussion. We actually had this session live a few days ago, but there were a lot of audio issues with that, so I'm recording this session again. In case you're new here, my name is Dr. Amar Udare. I'm a fellow radiologist currently doing a fellowship at McMaster University, Canada in cross-section imaging. So without any further ado, let's start today's case discussion. So how it works is that we have 10 classic radiology cases. What these are also known as aren't mini cases. There's a single image. I'll wait for so what I'll do is I'll show a particular image and you guys can type in your answers in the comments section. I'll wait for around 15 to 20 seconds for each case, and then we'll have a short discussion for each pathology. We'll try to keep the discussion short so that we cover more topics rather than concentrating on a single case. So this is the first case. For those who have not had a lot of MRI postings, this is an actual T1 weighted image of the posterior fossa. Okay, so what we see here, so the additional history in this case was that this patient had a history of seizure disorder since childhood. So let's see, I'll give you a few seconds so that you can look at the image and type in your answers in the comments section. So what we see here is diffuse. I'll just switch on my laser. Okay, so what we see here is diffuse prominence of cerebellar foliae with relative preservation of the cerebrum. So what we see is diffuse cerebellar atrophy with normal cerebrum. So this is a typical finding in patients with phenytoin toxicity. So the answer in this case is cerebellar atrophy secondary to long-term anti-epileptic treatment. A few important points. Cerebellar atrophy can be congenital, secondary to drugs, or due to normal aging. Phenytoin is a known drug causing cerebellar atrophy. Another important cause, a relatively commoner cause, is alcohol. So I have a question for you guys here. What is alcohol-induced corpus callosum degeneration known as? You can type in your answers in the comment section and I'll reply to those with the correct answer. A hint here is that it's a 3-letter word and it starts with an M. Okay, moving on to the next case. So what we see here are actual GRE based images, and I'll let you identify the findings and see if you can put them together. Okay, so what we see here are these multiple foci of blooming, which are seen predominantly in the basal ganglia region, the thalami, and a few at in the cerebral cortex and gray-white matter junction. So this is a typical case of chronic hypertensive angiopathy. So what we saw here is a GRE based sequence. So what happens is that in GRE, if there is calcification or blood, these structures appear more hypointense than they occur on, say, a T2 or T1 based sequence, and that is the exact definition of blooming. So for blooming to occur, the signal on SWI or GRE based images should be more than that of T1 or T2. As I said, these are best appreciated on GRE and SWI based sequence. A common differential for this, which is often ignored, is cerebral amyloid angiopathy. The difference in that case is that the hemorrhages in that case are more commonly cortical in location rather than the basal ganglia, pons, or cerebellum, which are more typical of chronic hypertensive microangiopathy. Another differential is multiple cavernous malformation. but that is very rare as compared to the other two differentials. So this is another case. This was a young patient who presented to the emergency with acute left lower quadrant pain. I'll give you a few seconds to identify the abnormality and move on to the finding. So what we see here is adjacent to the descending colon, there is a fat density area. It's also appreciated on the sagittal plane. So you see this small fat density area. So what we see here is a small hyperdense area adjacent to the descending colon, and this was the cause of the patient's symptoms. So in case you have not got this is acute epiploic appendicitis. This is a self-limiting inflammatory / ischemic process involving the appendix epiploicae of the colon. These are fatty tissues which are seen in close proximity of the colon, and because the rectosigmoid and the ileocecal junction have these in abundance, we commonly see acute epiploic appendicitis in this region. The signs associated with these are hyperattenuating ring sign and a central dot sign. We have discussed this pathology in detail in one of our lectures, and I'll leave a link to that either in the description section or as a card write-up in the corner. The common differentials for this are an omental infarct. However, an omental infarct would be larger in size, say usually more than 5 centimeter. Moving on to the next case. So this is an MR angiogram of the head and neck. I would like to identify the normal variant what we see in this case. So this is the arch of aorta, and these are the major vessels that are coming off the arch. Okay, so the variant here is what is known as the bovine aortic arch. Normally what happens is that the right brachiocephalic trunk and the left common carotid artery and the left subclavian artery arise as 3 branches of the aorta. What's happening here is that the left common carotid artery and the right brachiocephalic trunk have a common origin from the arch of the aorta. So this is a anatomical variant known as bovine aortic arch. So it's the most common aortic arch variant, and as I just showed you in the image, what happens here is that there's a common origin of the brachiocephalic trunk and the left common carotid artery from the arch. Interestingly, this bears no resemblance to the aortic arch branching pattern found in cattle. So it's kind of a misnomer. Coming on to this knee MRI case, I'll give you some more time because this is an MR case, an MSK MRI case, which can be a bit difficult for a few of you. I'll describe the anatomy till then. So this is an axial MRI at the level of the menisci. This is the larger medial meniscus, and this is the smaller lateral meniscus. And I would like to identify the pathology in this case. Okay, so this is what is known as a parrot beak tear, and it involves the lateral meniscus. So what are parrot beak tears? Parrot beak tears are vertical flap tears that have radial and longitudinal components, which typically result in a flap of unstable meniscal tissue. These usually start as radial tears and then propagate as a longitudinal vertical tear. Some authors suggest that the term should be avoided on radiology reports and should be strictly used only in arthroscopy reports. Okay, so this is our next case. This is a coronal CT, a coronal non-contrast CT of the facial bones. and I'll wait for some more time for a few people to answer. So this is a blowout fracture of the inferior wall of the left orbit. What we see here on the right side is a nice continuous orbital rim. On the left side, the orbital rim is interrupted and there is this inferior wall fracture with herniation of orbital fat. So what is a blowout fracture? If there's a fracture which involves only one wall of the orbit with a maintained orbital rim, we can call it that as a blowout fracture. Most commonly, the inferior wall of the orbit blows out. In children and young adults, because of the elasticity of the orbital floor, what can happen is that this fractured fragment can get back to its own place. However, the herniated tissue will get trapped in the fracture. So that's a pathology that you have to carefully look for. Commonly, these extraorbital muscles can get trapped in the structure, but if the fracture is large enough, any orbital content can get trapped in these fractures. So this is another MR angiogram. This time this is a sagittal MR angiogram of the head. What we see here is this odd shaped vessel. It's difficult to identify in a single image, but I'll let you know the diagnosis, and then in future such spot cases that will help you. So what this is known as, this is a tau sign. Tau is a Greek letter, and this is a case of persistent trigeminal artery. So persistent trigeminal artery is the commonest persistent carotid vertebro-basal anastomosis. In the fetal circulation, there are multiple of these communications in the anterior and posterior circulations, which get resolved or resorbed in the adult life. If they are persistent, they can give rise to these not so common vascular channels. This is not pathology, these are just anatomical variants. So the trigeminal artery in the fetus arises from the internal carotid artery, commonly the petrous or the cavernous ICA, and then supplies the basilar artery. There are classifications of these depending on what part does it supply. However, they are not that clinically relevant. Moving on to the next case. So this was a young female who had this abnormality for a long time. I think it was more than 15 years that she had this lesion. So this is an axial T1 weighted image, and this is an axial T2 weighted image. So what we see here is a ill-defined T2 hyperintense lesion with multiple linear hypointense areas, giving rise to what is known as a tiger strip pattern, and the lesion is fairly T1 iso-intense. We can hardly appreciate it on the T1 weighted images. So this case is Lermite-Duclos syndrome. So this is also known as dysplastic cerebellar gangliocytoma. What this is a hematoma or a neoplasm. There is controversy whether we should call it a hematoma or a neoplasm, but these are typically very slow growing tumors. They are commonly associated with Cowden syndrome, and when they occur together, what the term used is cold syndrome. So CO for Cowden and LD for Lermite-Duclos syndrome. T2 weighted images, as I shown you previously, show a tiger stripe pattern of alternating inner hyperintense and outer hypointense layers of enlarged cerebellar foliae. So moving on to the next case, this is a transverse scan in a antenatal ultrasound. again, in a single image it's difficult, so I'll just try to point out. So this is the fetal abdomen, this is the fetal chest, and this is the fetal subcutaneous soft tissue. So what we see here is extensive bilateral pleural effusion, mild ascites, and extensive subcutaneous edema, which measures almost 3.6 centimeter. Usually we hardly see any subcutaneous soft tissue in a fetus. So this is a case of fetal hydrops. What happens is that there's extravasation of fluid into third space, which could be due to multiple reasons, including heart failure, volume overload, decreased oncocytic pressure, or increased vascular permeability. The signs for hydrops fetalis include fetal pleural effusion, pericardial effusion, ascites or generalized body edema. We saw all of these in our case. Additionally, there can be nuchal edema or cystic hygroma, placental enlargement, and polyhydramnios. In earlier, immune causes were very common due to Rh incompatibility, but nowadays the most common causes are non-immune causes. So coming to the last case for today, this is a multiple axial and a coronal sequence of the brain, and I would like you to type the complete diagnosis in this case. So this is diffusion, this is ADC, this is diffusion, this is a T2 weighted image, this is a T1 image, and this is a coronal T2 image. So before we move on to the answer for this case, I would like you guys to give your feedback about the current case discussion and the previous case discussions that we had. If you like the discussions we have had so far, please press the like button. If you do not like these lectures for any reason, feel free to push the dislike button, but please mention your feedback in the comment section. What would you like to improve in these lectures? And for future video updates, you can always subscribe to the channel. We do a lot of live sessions where you can actively participate in the cases, and there are other recordings from our previous webinars which you can also access. So moving on to the diagnosis in this case. So the complete diagnosis is bilateral subdural hematomas causing descending tentorial herniation, which is compressing the left PCA with a resultant acute infarct. I'll just go over these findings in this image. So what we see here are these bilateral subdural hygromas. Commonly we see them, but we should make sure that we look into the complications as well. So what's happening here is that there is mass effect because of these hygromas that is compressing the left posterior cerebral artery in this region, and that's caused an acute infarct. So if you see, there is hyperintensity on diffusion with low ADC values, which is typical of an acute infarct. So these subdural hematomas are most commonly in adults, and trauma is the most common cause. But if you see them in children, you should always think of non-accidental injury. That's one of the causes that is often neglected. And as hemorrhage everywhere in the brain, it follows that typical T1 and T2 signal pattern. So revising today's cases, we saw a case of cerebellar atrophy due to phenytoin. We discussed multiple GRE blooming foci in a case of hypertensive angiopathy. We saw an interesting case of acute epiploic appendicitis, which is a touch me not condition in the abdomen. This is self-resolving, so that's something important that we should mention. We saw an anatomical variant in the form of bovine aortic arch and tau sign in persistent trigeminal artery. Parrot beak tear, the menisci are a type of vertical tears. blowout fractures, and what is a trapdoor fracture, what is Lermit-Duclos syndrome, and what is cold syndrome, what is hydrops fetalis, and what signs we should look for on antenatal ultrasound. And lastly, we discussed subdural hematomas, which were causing a lot of mass effect and acute infarcts. So thank you guys for watching this video, and for more such content, make sure that you subscribe to the channel and do share the video with your friends and colleagues. Thank you, and I will see you guys in the next